So obesity and reproduction, we must agree that obesity is a modern epidemic. It's a modern epidemic. There's infection and so on has been settled, but we are dealing with obesity, which is actually the new modern epidemic. If you look at this statistic, okay, 30 years ago, obesity is not as great as what we see today. But today, whether it's developing country or developed country, we see that the rate of obesity is actually high. And Malaysia, being one of the developing country, is also not spared from being hit by this epidemic. So, sorry sangat gelap Okay, tapi this is Malaysia. Okay, percaya this is Malaysia So, whether we like it or not, we always read the slogan Malaysia boleh, and this time we boleh again. We boleh, we menjuarai in the sense that in Southeast Asia, we are the highest. We are 44.2% of Malaysians actually fall into the category of obese. Some clapping hands. Okay, Indonesia 21%, Philippines 26.5%, Singapore 30%, Thailand 32.2%. Within the Southeast Asia, the Vietnamese are the leading most. That's why if we discuss about IVF and so on, we see that the success of patients in Vietnam is actually very high, because their population is actually very much different compared to our population, because they are very, very lean as compared to us. 44.2% of Malaysians are actually obese. Okay? So, in this is one of the headline of Sinar Harian a few years back, where the headline actually is very, it was put there, Malaysia negara orang gemuk. Okay, so it's actually something that we have to look upon. And if you look at the statistic, 40%, 2 out of 5 Malaysians are actually obese. Okay. Minority of the obesity are because of endocrine problem, but we cannot deny the rest majority of the obesity comes from two imbalance. There is imbalance between energy intake and imbalance between energy output. So we tend to take more, but we tend to lead a sedentary lifestyle. And this cycle can usually start right from the childhood. Look at our child, they are stuck to computer, they are stuck to games and so on, then they rarely go outside to play. So that ultimately will result in an increase in the intake and reduction in the energy expenditure. As a result of that, there will be surplus of energy, and this will subsequently be put into the fat, the bad fat in us. Okay, we all had this just now, very nice. Pagi makan apa? Bihun goreng tom yum. Ada kat situ tom yum, and then we also add kuih yang sedap. Santan, boleh rasa santan yang fresh daripada Kedah. People from KL, you should taste it. It's much better than KL, because this is an original santan. Okay, and you also eat pulut sambal. So how much calorie you have taken for the breakfast? Plus lunch, a good lunch, kari kepala kari ikan, which is very nice. So this is Malaysia. We celebrated events with food. We cannot deny, we celebrate occasions with food. Our birthday, we celebrated success with food. We celebrated pregnancies with food. This is our way, our Malaysian way. So, whether we like it or not, whatever we are taking is actually more than what we are supposed to actually take. And decreased physical activity, access TV, computer and PlayStation. Children were left at home alone because mom and dad were busy working, and most of the time they are left alone, either alone or with somebody else who don't monitor them. So they are being monitored by television and so on. So this will lead to decreased physical activity in school and home. Transportation. by car or school bus. Last time we used to cycle to school, used to walk to school, but they are being sent by car. If possible, the parents want to send them by car in front of the school, in front of the class. Kelas kat mana kalau boleh nak parking depan kelas tu. Kan, lepas tu mak bawa pula bag, tolong bawa. So this is a vicious cycle. Yeah? And we also are not confident to let our children go out and play because neighborhood safety is an issue. So whether we like it or not, they are stuck in front of television, and that actually contribute to the obesity rise starting from the childhood years actually. Right. Let's go to the real topic. Definition of obesity. How do we define obesity? There are many ways of defining obesity. Either you use the BMI, you use the waist-hip ratio, you use the fat measurement, but BMI is the easiest. There are differences between WHO definition of obesity and Asian definition of obesity. Asian has higher percentage of body fat, and Asian are at higher risk of getting cardiovascular disease at a lower BMI. Because of that, the criteria for Asian criteria for BMI cut-off, we take normal as 18.5 to 22.9, and when you are 23 to 24.9 is overweight, 25 to 29.9 is pre-obese, and more than 30 is obese. So there are a big difference in terms of how you classify between Asian and Caucasians. And other ways of defining obesity is measuring the waist to hip ratio. Yeah? Measure the waist, kawasan yang paling ramping, dan hip, kawasan yang paling melebar. And we measure these two and calculate the ratio. Okay? The best is to have a cylindrical type. Yeah, you have this pinggang kerengga like this, because when you have this, you have less fat in the abdomen, and fat in the abdomen is the one that contributes to a lot of morbidities. So we want to be pear instead of apple or avocado. So it tends to be guitar or pear, but does not want to be apple or avocado. This is a cardboard type. Okay. So which one are us? So we have to calculate. Yeah. So being overweight and obese carries not only morbidity to reproduction, but it carries overall morbidity to oneself. Yeah. Patients who are obese are at higher risk of getting diabetes, hypertension, heart disease, high cholesterol, gallbladder disease, osteoarthritis, obstructive sleep apnea, fatty liver disease, and also cancer. For every kilogram of weight reduction, you can actually improve your osteoarthritis. That is what orthopedic people would say. And you have OA, the first thing to do is actually to reduce your weight if you are obese and overweight. Okay. Now we go on to how does obesity has an impact on reproduction. It has in many ways. Yeah. So obesity definitely has impacts on reproduction right from the puberty till the menopause age. It can affect the menstruation. It can affect the fertility status of the woman. It can affect the pregnancy status, and also it can affect the fetal status of the mother. So how does it affect? These are the lists. I will go one by one. Obesity and pubertal. Obese teenage tends to have higher early menarche. This is because for you to have the event of menarche is the final event of an intact orchestra of the hypothalamic, pituitary, and ovarian axis. For you to have a period, you must have a certain proportion of body fat. However, if the body fat is too high, yeah, it would secrete a lot of hormones called leptin, which is secreted by the adipose tissue, and high levels of leptin will lead to earlier menarche. And subsequently, because of the leptin itself, it will also cause oligoamenorrhea because it will affect the ovulation of the patient. So patients who are obese also tend to have an irregular cycles because they have especially in PCOS lady, their menses are irregular. They can have once in every 3 to 4 month menses because they are PCOS and obese. The more obese they get, their menses becomes more irregular. So for example, if you have a patient who has PCOS and she has menstrual irregularity, her menstrual irregularity will be better if she has weight reduction, because weight reduction itself will control the menstrual irregularity. This is because increase in adipokines, which are produced by the adipose tissue, and these adipokines will inhibit the ovarian function and reduce LH pulse amplitude, and therefore ovulation will not occur, because we know ovulation is the final event which is triggered by the high amplitude LH. So if you have low amplitude LH, you will not trigger ovulation, and hence you will not have a regular menstrual cycle. Obesity and sexual function. In female, obesity is associated with impairment of desire, arousal, lubrication, satisfaction, and orgasm. Definitely, patients who are obese has less sexual desire compared to their counterparts who are thinner. And of course, when both partners are obese, you can imagine the difficulty in performing sexual act. Yeah? And males who are obese can also have erectile dysfunction. Okay, let's look about ovulatory dysfunction. There is a strong correlation between BMI and subsequent end ovulatory infertility. If you look here, if the lady has a BMI of 24 to 25.9, the chance of end ovulatory infertility is only 1.3. But if the BMI goes beyond 32, the risk of getting end ovulatory infertility increases to about 4. So, definitely, obesity has an effect on the ovulation. Okay? And we always see in patients who have irregular periods, when we advise them to reduce weight, they can actually have spontaneous conception. In PCOS, for example, if they reduce about 5 to 10% of their body weight, 40% of them will actually ovulate spontaneously. For example, you have an 80 kilogram PCOS lady. You ask them to only reduce 10%, which is about 5 to 10%, which is about 5 to 10 kilos. Reduction in 5 to 10 kilos will cause 40% of them ovulating spontaneously and pregnant spontaneously without even giving any ovulatory agent. So that should be the approach to managing patients who are infertile. Okay. If you look at, this is a study which was done on 500 women receiving donor insemination. That means they received insemination from a donor sperm. So what was noted is that when they measure the waist-hip ratio, with every 0.1 unit increase in waist-hip ratio, the normal waist-hip ratio should be less than 0.8. Okay? But if you have a waist-hip ratio which increased by 0.1, you will have a reduction in the chance of getting pregnant. If your waist-hip ratio is 0.7, 63% of patients will be able to achieve pregnancy in 12 months. But as you get obese, you get more abdominal fat, your chance of pregnancy will be reduced to only about 32% in 12 months of trying. The same goes with BMI. Okay? In a patient who underwent fertility treatment, we always would encourage patients to lose their weight before starting medication, because in patients who are obese, they need to have higher dosage of medication to stimulate the ovaries in IVF, and they will have a longer stimulation days and reduce the number of mature oocytes. In our setup, in any patients who are going to go for IVF, we always would defer until their BMI come down to less than 31. Yeah? In certain centers, for example in UK and H, they require the BMI to come down to about 30 before they can actually proceed to IVF. So that's why I think lifestyle modification is very important to achieve a good weight before we embark on any fertility treatment. Okay? And the success of IVF. When we do IVF, we can do. But what we want is success for the patient. We know that in obese patients, the success of IVF is reduced. Pregnancy rates after IVF is 50% lower if the BMI is more than 30 kilogram, 30, compared with women with BMI of less than 25. So I think this statement should be a motivational for our patient who is going for fertility treatment, because at the end of the day, not that we just want to do the procedure. What we want is we want success for every procedure that we do for the patient. So this is a study which was done in Adelaide. So it is noted that with increasing BMI, the chance of achieving pregnancy is lower, okay? And the chance is best when the BMI is put in the ideal BMI. The same goes with cumulative live birth rate. It was noted that the cumulative live birth rate is actually higher in patients who has normal BMI as compared to patient who has higher BMI more than 30. Okay. What about the oocytes that we collect from patients who underwent IVF? Does it differ from a patient who has normal weight? Yes, there is a difference. Oocytes in patients who are obese tends to be smaller and they have more meiotic defects, and therefore they have reduced fertilization when we fertilize with the sperm, and also impairs the embryonic quality. The blastocyst has less cell and less expansion of the blastocyst. So that's why it contributed to a lower pregnancy rate in patients who are obese. Okay? This finding is illustrated in a patient because it can be overcome by using donor oocyte from a lean patient. That means if you use a donor oocyte, you implant in the obese patient, you will see that the pregnancy rate is higher compared to the using their own oocytes. And this is to show that obesity has an effect on the oocyte itself. Okay? But again, obesity also has an effect on the endometrial, because obesity will alter the endometrial receptivity during IVF. And this is again, because if that one is demonstrated in oocyte cycle, in the donor cycle, this is demonstrated in surrogate cycle. You get the embryos, but you implant it into a surrogate who are thin. It is noted that the pregnancy rate is higher in a surrogate who has a normal BMI compared to a surrogate who are obese. So it shows the factor of endometrium here that caused the reduction in the pregnancy. And miscarriage, as I mentioned just now in the talk regarding miscarriage, we know that obese women experience higher miscarriage rate and lower live birth rate. And if we are doing procedures for patients who are obese, the procedures are going to be difficult. One is difficult to do an ultrasound for the patient. Number two is difficult to do a egg pickup for the patients, and also difficult to do a transfer for the patient. So obesity definitely have an interference on the procedure itself. Okay, so egg pickup you find that it's slightly difficult to do, and also on embryo transfer, because you have a thick abdomen, you will find it's difficult to actually see where you put the embryos. So pregnancy rate is going to be higher if you have a good embryo transfer technique and also embryo transfer visualization. Okay. In obese male, what happens is that the leptin will act on the hypothalamus pituitary ovarian, the pituitary axis, and cause a reduction in the FSH and FH. Because of that, so obese men are being afflicted by erectile dysfunction, difficult sexual act, and also low sperm parameters. So what has been concluded is that in the meta-analysis of 21 study on 13,077 men, risk of low sperm count is 1.28 in overweight male, but it increased to 2.04 in obese male. So that's why when you see an infertile couple, telling them to reduce weight on both partners, the female and male, will actually do a lot of difference to subsequent fertility treatment and also fertility outcome. You can do as, for example, at KK or at a district level before you refer them to tertiary centers, lifestyle modification of weight And also other lifestyle modification, for example, like smoking, alcohol intake and so on, caffeine intake, can actually do much difference to the success of the patient. Okay, next I'll move on to effect of obesity on maternal and perinatal health. Let's say the mother of obese mother succeeded in getting pregnant. She is actually at higher risk compared to a patient who has normal weight. And what are the risks that she suffers? She has higher risk of miscarriage, she has higher risk of cesarean delivery, she has higher risk of developing other pregnancy complications, for example, gestational diabetes and also hypertension. And she is also at higher risk of getting postpartum infection and postpartum thromboembolism. So the cost of managing obese pregnant is 5 times higher than the average. Increased risk of hospital admission due to PET and diabetes, increased risk of operative delivery, postpartum complications, and also higher cost because of NICU admissions for the babies. Okay. This is a table summarizing the obstetric complication in obese pregnant women. If you can see here, the risk of miscarriages is higher. The risk of congenital anomalies, namely the neural tube defect, spinal bifida, congenital heart disease, omphalocele, is actually significantly higher compared to the lean population. And other late pregnancy complications, for example, hypertensive disorders, gestational non-proteinuria hypertension, preeclampsia, gestational diabetes, preterm birth, and IU, intrauterine fetal demise, are actually also significantly higher in patients who are obese compared to their lean counterpart. Okay, with regards to peripartum events, you can see that there is higher risk of cesarean delivery, operative morbidity, and also neonatal complications such as fetal macrosomia, shoulder dystocia, and also high birth weight. That's why I always say to my patients who are obese and who wanting to embark on fertility treatment as soon as possible, I always say to them, saya berdosa kalau saya akan buat rawatan kesuburan sekarang. Sebab nanti you akan dapat all the complications. So lebih baik turunkan berat badan dulu. Kalau saya buat sekarang, saya berdosa. So I always say that because I think it's not worth doing. You get her to get pregnant, but she's facing all these complications, not only causing morbidity to her, but also can cause mortality to a certain extent. So that's why it's very important to keep her fit and reduce the BMI before you embark on treatment for the patients. So obesity and VTE risk, pregnancy is a prothrombic state. Obesity itself trebles the risk of thrombosis and pulmonary embolism. And because obese individuals in pregnancy will have a higher factor 8 and also factor 9. So this will put them at risk of thrombosis state and also VTE risk. Okay, right. Recommendations for weight gain. We always get that figure of 12 kilograms. As if everybody, okay, semua naik 12 kilogram. It's actually not, yeah. So it depends on the BMI. If you have a normal weight pre-pregnancy, yes, you will require the patient to go for about 11 to 12 kilograms throughout pregnancy. But if you have a patient who start the pregnancy with a BMI of 30 BMI, you only require her to actually has a weight gain of about 7 kilograms. She cannot go and get 12 kilograms. She will be too obese by then, and she carries a higher mobility. So 12 kilograms is not the magic number that everybody must achieve. It depends on what is the pre-pregnancy state of the patient, whether she's obese or she's a normal BMI. So this is the most difficult. How do we manage obesity? It's difficult because it's difficult to stop people from eating, because eating is something which is nice, which is good, okay, which gives you, everybody likes to eat, okay. So how do we manage patients who are obese? If the BMI is between 30 to 39.9, the focus is still on behavioral modifications, which is diet and lifestyle modification through exercise. The pharmacological therapy and surgery are options for more severe cases of obesity where the BMI is more than 40. Okay? Can spot somebody here? Okay, that's spotted. So this is what we do. With our patients. The staff and patient joins together. Basically, patients who want to get pregnant and they are striving to reduce their weight, we together with them will go for classes to reduce the weight reduction. So we do Zumba, for example. We refer them to DRC, Diabetic Resource Center, which Dr. Shafinas, the endocrinologist, has set up, where the patient will be advised on how to reduce weight, and patient will have their own group. So each of them motivates each other to actually reduce weight. If one of them gets pregnant with weight reduction, that will actually be a best motivator for them to continue to lose weight. Okay? So the aim of dietary intervention is actually to reduce the body weight. Not only that, it also reduces the insulin resistance, reduce the impact glucose function, and also reduce the risk of hyperlipidemia. Okay. So what's the best diet to actually reduce? So there are so many suggested regimes, intermittent fasting, Atkins diet, low carb, high protein diet, and so on. But there's no one diet at the moment which proves to be better than the other. What is more important is actually to restrict the calorie intake and calculate the calorie intake of the patient. Yeah? So eat less and exercise more, that's the most ridiculous fat diet I've heard of yet. So that's what the cartoons say. But it's actually true. If you look here, the energy requirement of a probably 80 kilogram patient is actually about 1,800 to 2,000 kilocalorie. If you want them to reduce weight, you actually must calculate the diet to be about 1,500 kilocalorie per day. So by doing this 1,500 kilocalorie per day, you are cutting about 3,500 kilocalorie per week, and that will actually reduce about 1 pound of fat. You can actually achieve weight reduction. So how do you calculate 1,500? So you have many apps now which you can actually log to. Yeah? So there are calorie counter, there are my plate, there are so many apps, there are fitness apps and so on, which you can actually put whatever you have eaten into the calculator, and it will calculate how much calorie that you have taken. For patients who wants to reduce weight, we actually advise them to take about 1,200 to 1,500 kilocalorie per day. So there's no restriction on what food you can take. You can take any food. You can even take nasi lemak, but you probably can only take about 3 to 4 scoops of nasi lemak and calculate how much calorie you have taken. So calorie restriction is actually the best that you can do to actually put the patient to weight reduction. But during the early days of calorie restriction, there must not be so many cheat days. Okay? Because if you can see here, if you manage to do 1,500 kilocalorie per day, and you had a deficit of 3,005, and you go for 1 gyros, for example, with good foods, so that's your cheat day. The cheat day, you have actually gained what you have suffered for the whole week. So not many cheat days in the early time. Okay? I'm finishing. So the RCOG guidelines, there's no evidence for one type of diet. Strategies may include pharmacotherapy, bariatric surgery, and avoid pregnancy during the weight loss. So occasionally, we can use pharmacotherapy to actually has an impact on weight reduction. And bariatric surgery is the most effective weight loss treatment for morbid obesity. That means more than 40 BMI. And generally available to women with BMI of more than 40 or with BMI of more than 35 with comorbidities. So bariatric surgeries are many procedures that has been done. Either you are doing the restrictive procedures or mal-absorptive procedures. But mind that every patient who has undergone bariatric surgery, we should defer the pregnancy until a year post bariatric surgery, because we are afraid that the fetus will be severely malnourished. Okay? So conclusion, obesity is associated with ovulatory dysfunction, reduced ovarian responsiveness, altered oocytes and endometrial function, and also lower the birth rate. Obese women are also at increased risk of developing fetal and maternal complications in pregnancy. And lifestyle modification with exercise and dietary modification, followed by adjunctive medical therapy. And bariatric surgery is an important adjunct, but pregnancy should be deferred for 1 year post-op. And the health benefits of postponing pregnancy to achieve weight loss must be balanced against the risk of declining fertility with advancing age. For example, you have a 40 years old, you cannot spend too much time for her to reduce weight, because by that time she also will lose her ovarian capability of getting pregnant. So you must put her on crash diet and so on, probably do surgery so that she can reduce weight as much as possible, and followed by fertility treatment. So with that, I thank you, and let's cruise. Jom cruise. Okay?